health, as we continue to recognize and see that society often shuffles Black women on the side, but yet expect us to continuously fight on the front lines. This is where I believe the role of patient advocacy and cultural competency intersect to alleviate some of the burden that Black women face in regards to maternal and child health in clinical settings. Especially in the pandemic, in which women often do not get to go to prenatal appointments with their family and friends, doulas can provide the critical emotional and spiritual care needed during one's pregnancy. Working as part of the Black maternal health research team at the Yale School of Medicine, which focuses on the experiences of Black women with pre-existing conditions of hypertension and diabetes during pregnancy, I have learned that that type of care can be essential and effective in times in which moms and moms-to-be feel that their concerns and voices are not being heard. In addition to exploring the ways in which we can improve care outcomes for Black women and women of color across all socioeconomic backgrounds, it is important not to lose the voice of women we are fighting to protect. In our research and work exploring about how we can make a difference, we must ensure that we center their voices and work to ensure that we are looking out for women every step of the way. As an aspiring physician and community leader, I sincerely hope that conversations like these can help to uplift the voices of Black women in healthcare and provide an important step forward in alleviating health disparities in communities of color. I know that this panel, with all these amazing women doing such impactful and incredible work, can help to shed more light on what we can do as health service workers and executives to care for the most marginalized communities. At this time, I would like to introduce our esteemed moderator, Dr. Natalie Achong. Dr. Achong is a board-certified obstetrician gynecologist and a fellow of the American College of Obstetricians and Gynecologists. She currently serves as a governing council member for the American Medical Association and was the 225th president of the Hartford County Medical Association. As a physician executive, described as a physician catalyst, Dr. Achong has been the primary contributor to groundbreaking projects in population health and healthcare disparities in Connecticut's healthcare systems. She works closely with regional agencies and foundations on broad diversity initiatives to help develop and support programs for diverse patient populations. She has been the director and PI for several programs to educate physicians and other medical providers and students on exclusion, diversity, and inclusiveness in healthcare. Dr. Achong completed the accelerated 7-year BSMD program at the Sophie Davis School of Biomedical Education of the City University of New York and received her medical degree from New York University Medical School. She completed her residency training at Yale University School of Medicine, where she was teaching community faculty in the Department of Obstetrics, Gynecology, and Reproductive Sciences. In 2016, Dr. Achong graduated with a master's degree in healthcare leadership from Brown University. We are so appreciative to have Dr. Achong moderate today's panel, and I will now let Dr. Achong have the floor. Oh, you're on mute.
Okay, thank you, Simi, for that wonderful introduction. You're very kind, thank you. At this time, I would like to do an introduction of Dr. Lucinda Canty. I've known Lucinda for many, many years, and it is my honor to have her on tonight's panel discussion. So let's hear a little bit about Dr. Lucinda Canty. Dr. Canty is a certified nurse midwife and assistant professor of nursing at the University of St. Joseph in West Hartford, Connecticut. She received her BSN from Columbia University and her MSN from Yale University, specializing in nurse midwifery, and her PhD from the University of Connecticut. The title of her dissertation was "It's Not Always Rainbows and Unicorns, the Lived Experience of Severe Maternal Morbidity Among Black Women." What a title. I'd love to hear more about that. Among her many research interests include the prevention of maternal morbidity and severe maternal mortality, reducing racial and ethnic health disparities in reproductive health, promoting diversity in the nursing field, and eliminating racism in nursing, very important. She currently provides women's health at Planned Parenthood and hosts a webinar discussion on the reckoning of racism in nursing. Dr. Canty will now share with us her comments on this important subject before us and help ground our discussion. Dr. Canty.
Thank you for the introduction. So again, my name is Lucinda Canty, and I'm going to share my dissertation research on the experience of Black women who suffer severe complications, life-threatening complications, either during childbirth or postpartum. I'm going to use their experience to show you where doula care is needed, and the panelists will further discuss, the importance of their care. Next slide. Oh, sorry, are the slides? Okay, are the slides, oh, there we go. Okay, perfect. In my research, you'll see artwork throughout. The artwork is my artwork, and it's based on the experience of the women as well. Okay, so next slide. So we all know that the United States is in a maternal health crisis, and we know that Black women represent disproportionately the number of maternal deaths and those that come close to dying. For every maternal death, about 100 women will come close to dying. And so I want to talk to those women. Next slide. Okay. And so I'm going to talk about the themes that I found that was very common throughout the women that I interviewed. And these women suffered preeclampsia, pregnancy-induced hypertension. They had postpartum hemorrhage, losing severe amounts of blood after delivery. There's also a woman who had sepsis and cardiomyopathy or heart failure. And these were all women, I just want to state, these were all women that started prenatal care early. They all had education from high school all the way up to their PhD. They were working, they had access to care, and they still found themselves with poor maternal health outcomes. They all survived to tell their story. But level of knowledge was one of those areas where women felt like they needed more. Some women never heard of their condition. They didn't know the side effects, I should say the signs and symptoms. They didn't know the risk factors. They didn't even know they were at risk. And there was one who had like a severe headache, which is a sign of preeclampsia, and she was driving her car. She took 2 Advil and was doing chores, bringing her daughter to daycare because she didn't know. There were other women who knew about their condition, but they didn't know how severe it was. One woman told me, I thought preeclampsia was your ankle swelled a little bit. I didn't know that I could die. I didn't know it could impact my liver and kidneys. So women expressed a need to be educated. Next slide. Okay. And the relationship with the healthcare provider is essential, whether we're going for our routine checkups, but when we're looking at pregnancy and childbirth, women are at their most vulnerable. And the relationship with the healthcare provider really helped, either make them have a positive or negative experience. Those who had positive experiences or strong relationships said that their providers trusted them, they respected them, they talked to them like they were human, that they were part of the care. Women who had weak relationships or very negative experiences said that their providers, they felt like they were just part of their routine. They took care of the technical pieces, checking their blood pressure, measuring the baby, listening to the fetal heart rate, but they didn't really have an emotional connection. And they felt like they didn't have a voice, that they weren't heard in their care. Next slide, please. And those who had negative relationships felt that the healthcare providers they called racism when they didn't have that strong relationship. They felt that the color of their skin dictated the care that they received. They felt that they weren't seen or heard. They felt like they weren't trusted to know and understand what was happening to their bodies. So when they reported symptoms, they were dismissed. Or one woman called and said she took her own blood pressure, it was 170 over 110, told the provider, and he said, okay. So she was like, should I come in and be seen? He was like, oh yeah, sure, come in. So she got in her car and drove herself with stroke level blood pressure. And she ended up being hospitalized for 10 days to get her blood pressure back under control and to have her safe. So the women definitely felt like race had an impact on their care. Okay, next slide. So the next 2 areas go together. Faced with uncertainty, where these women found themselves in the hospital and learning that there was a chance that they could die. They felt they were in a very lonely place. They just had their babies. They wondered about their families, who was going to take care of their babies. They thought about their mortality for the very first time. And death should not be associated with childbirth. I could go to any male, female, anyone on the street and say, when you think about childbirth, what do you think about? Everyone says pain. Give me my epidural. You know, whether you had children, you didn't have children, you focus on pain. No one focuses on death. So just to let you see the emotional impact of where these women were. And again, this ties into my next slide. Still healing. The women, they range from 8 months to 18 years postpartum. And they were still healing emotionally. They healed physically, but mentally they were still healing. They felt that there was trauma in their in their experience, because they just weren't prepared. And even the healthcare providers, again, they could either be a source of support, but a lot of women felt them as to be a source of trauma. And they were still dealing with that. Even after there was one woman who was so traumatized, she had to have an emergency cesarean. They started to cut her and she was feeling it. She's like, I'm feeling that. They kept right on cutting. And they said, well, we got to get the baby out. So after that, she didn't even want to go to the doctor. She never went for her 6-week checkup. She went like 6 months later. And then now she's like, I don't even want to go for my yearly checkups, that she's still traumatized. And this woman, this was 10 years ago. So just to let you see how this impacted them and how it impacts their future care of themselves. So they also said that they weren't assessed mentally, like no one checked in with them. There was a young lady, 23 years old, who had to have an emergency hysterectomy. She had her first baby. They did a cesarean on her. They couldn't stop the bleeding and had to do an emergency hysterectomy. And she said the next day, no one said, oh, how are you? You know, tell me what's going on. You just went through something very serious that's going to impact you. She said people came up to her, they wanted to avoid talking about it. Or they said, did you have a good day? You know, we heard you had a bad day. How are you now? Are you better? But no one really asking about what that meant to her. Or even saying, I know you're overwhelmed. You may not have questions now, but here's a number you could call to get help. So these women really wanted that emotional support. Next slide. Okay. So if we're going to improve maternal health outcomes, we have to look at patient education, culturally appropriate care. These women said that their providers were not even aware of their own implicit bias. They just weren't aware of it. Having a relationship, a strong relationship with the healthcare provider. Again, there has to be trust. And having a mental health evaluation and support. And doulas can address all of these areas. Okay, next slide, please. Okay. And this is a quote from Sister Song. Reproductive justice includes access to all birth options for all people. And in this presentation, I do focus on Black women because Black women, we have the worst health outcomes. But I feel like if you improve the health of Black women, you improve the health of the community. If you improve maternal health for Black women, you improve maternal health for everyone. And I just want to show you, this is a graduation from Earth's Natural Touch. I do consulting with them. This is the birth center, I want to say education, but they have doulas. This is a doula graduation. And I just want you to see that there's an army of doulas in Connecticut who are already working in the community. They just need support. They need to be acknowledged for the work that they do and compensated for the work that they do. So I just want to uplift them and again, show the importance of what they have to offer to Black women. If we want to improve health outcomes, there's so many things that we can do, and it doesn't mean that it's going to cost a lot, but it's going to improve their experience and their overall well-being. Okay, so thank you.
Thank you, Dr. Canty. We've practiced together, you and I. So for you to speak to those issues so forthrightly, it really resonates, I'm sure, with all of our participants and certainly with me. I celebrate the work that you've done.
Thank you.
Chi, at this time, I think what we'd like to do is share what are the pre-poll questions, results. Do we have those results?
Yes, absolutely. So the first question that we asked everyone was, how many times have you heard of doula services? And we had about 92% overwhelmingly respond that they have heard of doula services at least a few times. And then our next question was, what type of support does a doula service provide? And the options were emotional support, physical support, informational support, advocacy, and all the above. And 96% of the respondents responded that all of the above are support that doulas provide to mothers.
We have a very informed audience tonight. That's wonderful. So we will have a very rich discussion, I'm sure. What we have is another question, just to go with the interaction for tonight. It's going to be presented to you in the chat box in terms of true or false. So I believe that's going to be launched. Is that right? Okay, very good. So we will hear more about that. And at this time, I'd like to introduce our incredible panelists for this evening. It would basically take me all night to go through all of their accomplishments and work and contributions to women's health that have been done locally, as well as nationally across the globe. So we're not going to do that. We're just going to go through each panelist for tonight and then have us go into our Q&A session and get the results of the poll question. Our first panelist is Sarah Emanuel. Sarah is the co-director of GRA Health Initiatives and Environmental Science, entrepreneur and educator. She is the president of Family Development and Samaritan Foundation, a nonprofit that stands to be the voice for the voiceless. Sarah strongly advocates for women and families around the globe and works tirelessly to improve the health of individuals and communities by expanding their access to healthcare. She has created innovative, enriching programs that provide medical services all over the world, including Uganda, Congo, Cameroon, and Nigeria. Thank you, Sarah, for joining us. Our second panelist is Ashley Minahan. Ashley is very passionate about working with families. She has held numerous supportive roles, including facilitating parent-child groups, supporting foster parents, home visiting, and working with families in the perinatal period, such a critical period to what we're talking about tonight. Over 4 years ago, Ashley left the agency where she worked to actually start her own business, Empowered Beginnings, which provides childbirth education, lactation, counseling, and doula services, and has served hundreds and hundreds of families across Connecticut. We have tonight as well, Dr. Madeline Sutton. Dr. Sutton is the founder and CEO of One Brain for Health, which is aimed at achieving health equity through science and mentoring. She has always been passionate about mentoring historically underrepresented groups, early career scientists and clinicians. Dr. Sutton earned her bachelor's from Georgetown University, her doctorate of medicine and master's in public health degrees from Columbia University, and completed her OBGYN residency at the University of Medicine at Rutgers University. She is a board certified gynecologist with more than 20 years of patient care experience. She is also a medical epidemiologist, a nationally recognized author, and a consultant. Dr. Sutton is currently faculty at Morehouse School of Medicine. Her expertise has been shared all over the world. Dr. Sutton has traveled and served in Haiti, South Africa, and Ghana, and has been discussing real-world strategies to help decrease reproductive health strategies and have women take control of their own bodies. Dr. Sutton is also, in addition to everything else, a retired veteran of the U.S. Public Health Service, having served as the lead for the Minority Health and Health Equity Research activity in the Division of HIV/AIDS Prevention at the Centers for Disease Control. Her life mission is to improve access and health outcomes, especially for women of color. Thank you, Dr. Sutton, for joining us. Whitley Mingo is a maternal child health social worker, certified birth doula, and childbirth educator serving right here in Connecticut for many years. Whitley is a very familiar face within the community, a trusted person as a dedicated worker in the field of social work, and also providing perinatal outreach and parent education to pregnant and postpartum families. Whitley is personally and professionally dedicated to advocate for families of color. Her work with New Being Doula Services addresses disparities in pregnancy, birth, lactation, and postpartum outcomes. Whitley provides free prenatal support to groups and BIPOC families. Thank you to all our panelists. So with that, what I'd like to do, and I'm encouraging you all to have your questions, just type them into the chat and then we'll go through them. We have questions that we're going to go through to spark conversation. But our goal tonight, in addition to all the advocacy and spurring and sparking new conversations among those who are like-minded and maybe those who are new to this discussion tonight, is to ask questions, but we're going to start with some basic questions. So this first question is for Whitley. In the area of doula services, what is a doula and what type of services do doulas support, especially around addressing health disparities? And are doula services actually covered by insurance? Whitley?
So the term doula is actually a very ancient term. So it derives from a Greek terminology meaning servant. And so throughout history, women have always played a role of supporting a birthing individual or a female throughout their birthing journey. And so as time has evolved, the term has now progressed to describe a certified or trained individual that supports a family emotionally, physically, provides informational support, as well as advocacy. A doula does not provide any medical tasks such as vaginal exams or typically blood pressure checks, things of that nature that a midwife or an MD would. So when I say that a doula provides emotional support, physical support, and informational support, it is still very vague, right? People really don't have an understanding of what that looks like. And so in light of current situations, such as COVID, families are not able to enter the birthing space with a maternal figure, oftentimes the way that they typically have. So families have to choose between having their partner in the hospital with them or their mother. And so a doula is able to come in and provide you with that education and support that you might receive from that maternal figure. We're able to support with massage, counter pressure, support around making decisions regarding your own body, as well as what's going to happen with your baby. We are also able to be present to provide you a sense of pride and to see your birthing experience in a more positive light. I believe someone mentioned already, when you walk up to someone and you ask them about birth, what does that mean? They typically resort to thinking pain. And so a doula is going to be there with you throughout that prenatal journey to help you look at birth in a different light. It is going to be a period of time of evolution changing, where a mother is now going to be stepping into that new role. And so we're able to just sort of support the mom along that journey to provide her that help, as well as now blood pressure, diabetes. We're able to really tailor our care and center it towards what the mother's needs are to ensure that she is educated and informed before entering that birthing space, so she is not now sort of intimidated into making a decision that does not best fit her needs or her family's needs at the time. So there are various forms of doulas. You can have a birth doula, there are postpartum doulas, there are antepartum doulas. And so there are doulas that are gonna guide you and walk you through every phase and stage of that birthing experience. And the further question was, is doula care currently provided or covered by insurance? And unfortunately, it is not here in Connecticut. In some states, it is covered by state entities and grant-funded services. However, it is an out-of-pocket expense, therefore making doula service a really great baby shower gift, or a gift that you can provide for a family member or friend to just give them a few hours for that postpartum care to ensure that they're receiving the support that they need. Because with the generations that we have now, not everyone has that family member or that support system that they can rely on. So unfortunately, doula services is not covered by insurance, but those are a few ideas of how we can cover that service for our community.
Thank you. Thank you for that response. What I'm hearing in your response is the importance of a holistic approach to a woman's care, and not just the woman, but actually the entire family. And in that connection, where we are seeing that the maternal mortality rates in the United States are actually rising, we're seeing an increase. We're the only developed country in the world with rising maternal mortality, and so much of that is mired, unfortunately, in the Black woman experience. To have an advocate and someone who was there regardless of your pregnancy outcome or where you are in the pregnancy is such an important thing. So I look forward to your comments in the panel discussion as well. Okay, so with that, we'd like to also move on to the important role that doulas can play in maternal health. So with that, I'd like to ask Ashley and Dr. Sutton, just to level set, what are the key differences that we should be aware of when considering doula services, midwife or an obstetrician? Why would one go to one versus the other? Can we see all at the same time or just one during the pregnancy? Dr. Sutton and Ashley?
Sure. Ashley, would you like to start and then I can follow?
Sure, absolutely. So doula services really complement the care of a provider. Doulas are not medical providers. We offer a different kind of support. A doula can help clients navigate their choices by providing educational information and evidence-based information as they go through the different choices. So they go to an appointment with their provider and they're sort of told some medical options or medical choices. And then a doula is there to kind of have that relationship with them and bridge the gap in between. We never give medical advice or manage their care, but we're a continuous support through the process and really assist clients in having conversations with their provider by forming questions that they can ask their provider. We have such a good relationship with them that they really trust us. And so if something doesn't feel right or something doesn't seem right, we can really encourage them to go back to their provider. A lot of times I hear from my clients that they don't feel heard by their provider or that they don't want to reach out because they don't feel like they're being listened to. So we can really kind of give them those skills to go back to their provider and be that bridge between the appointments.
Dr. Sutton?
Yes, absolutely. So, so just to piggyback on everything that Whitley and Ashley said, I completely agree. And by the way, thank you so much for the invitation tonight. This is a great panel, and it's great to see all the faces. So a lot of times, it definitely is possible to see all three at the same time. I think the latter question was, can you see an OB, a midwife, and a doula at the same time? Absolutely. Sometimes it depends on the mindset of the team members. Now, you know, for many obstetricians, when we're going through our training, many of us are exposed to and trained with or trained by midwives as part of our training process. That was one of my experiences when I was training in Newark, New Jersey. That's not the case for everyone. So, so when I respond that all three of those entities can work as a team, is from the perspective of, you know, that's where my mindset was at the time I went through training. And that's not the case with all OBs, but you'll find that a lot of OBs these days, if you review their office, if they have a website or something, a lot of them will have midwives that they work with in their practices. A lot of them might have doulas that they can reach out to if a patient expresses a desire to work with a doula as part of the team. And so absolutely, you know, when I look at the numbers that we see in this country in terms of maternal mortality, I look at this as an all hands on deck type of situation. And so absolutely the three of us, the OB, the midwife, and the doula can work together. Now, how is each role different? Each person has different roles and responsibilities and different levels of training. So you have the OB who's going to manage the medical aspects and, you know, do the full, and there will be some overlap because I'm sure all of us do a full history so we can understand what's going on. All three of us will try to make sure that in addition to understanding the medical history, we know what's going on socially in case we have to advocate and try to get some social support on board. The OB will, you know, manage whatever laboratory assessments have to be done. If anything happens which shifts that mom from a normal prenatal process to a high risk, the OB would manage all of that if any medications had to be prescribed. If at the time of labor, let's say the mom gets all the way to labor, everything is going great. She has opted to be managed by a midwife. Everything is going great, but let's say something shifts during the labor, such that a C-section is required. The midwife and the OB would work together. The OB would be the one doing the operative delivery by C-section. So, you know, those are definitely different roles, and the doula can support the patient through all of that, prenatally, in labor, as well as postpartum. So, so absolutely, you know, we think of it as a team process. And certainly with what we're seeing with maternal mortality, each person has an important role to play to make sure that that woman's care is as comprehensive as possible so that she has a strong outcome.
Excellent. Dr. Sutton, do you find that your colleagues or our colleagues are more receptive to that more of a collaborative approach than they used to be, say, in the past? How do you see that?
You know, I think that the newer trainees that are coming through are more open to it.
I agree.
Yeah, there are some older school folks, they're just not going to be open to it. They just have a different mindset. And so a lot of times, you know, we, especially back then, we were all kind of trained in these silos. You know, you do this over here, you do that over here. And there wasn't always a lot of overlap. And so there are some folks that feel that some doulas and midwives are, I guess, intercepting or crossing into their lane. That's not at all how I look at it. It absolutely, we need to cross into each other's lane as long as our patients, our moms, are getting what they need. But yes, Dr. Chung, we have some work to do in terms of trying to bring other OBs along to have that type of open mindset. You know, when it comes to things like caring for the patient and reimbursements and all that, I don't see there being competition. So the mindset just has to expand so that there's understanding that no one is trying to take away from someone else. We're just all trying to get our patients to a good outcome.
Yes, I agree. I agree. I think a lot of that has to do with the fact that these areas are now predominantly female. When I was in training at Yale, it was predominantly a male residency, and now most OBs in training are women. Most midwives, most doulas. So I think things are changing by virtue of who's in the workplace.
Absolutely, absolutely. I agree 100%.
Okay. Thank you, Dr. Sutton. We'll talk more. All right, we're going to raise a question with Sarah. Sarah, what types of spiritual, psychological, and/or sociological support could improve the experience of women of color during pregnancy and childbirth, and just the overall peripartum period from a women's health standpoint? So what is really needed during this time?
Thank you so much for that question. Thank you.
Of course.
Glad to be here today. Well, first of all, women's mental health and well-being is important as their physical health during or after pregnancy. So my response to this question would be to raise an ongoing awareness about women's health education, not just during Women's History Month or any day, any special day for women, and also to provide information about maternal awareness programs such as childbirth education classes, child education classes, maybe instructional videos and testimonials about maternal health and mental health programs. Also, benefits of having a doula should be discussed as an option and making it affordable. When when I was having children, those years, I never had a doula services. So it's something that is new. And I think it's something that we should make, we should discuss an option and make it affordable. Also, so that women of color can be well informed and be aware of available resources and support that, and they can take advantage of it. Also, it's also important for this expanded mothers to be in a women's support group of mothers, new mothers, expanded mothers. Is very important because when they're in that community, it would help them to be in a good spirit during pregnancy, and also it will provide emotional support, companionship, and also give room to ask a plethora of questions related to pregnancy. And also they'll be able to share the experiences, offer advice, and be of an assistance to each other. And of course, the dream of every woman that is expecting a child is to have a smooth and healthy full-term pregnancy. But sometimes the reality seems to show otherwise. And this is where spiritual support is necessary. having a strong spiritual support, having strong faith in God, and praying can help overcome the doubts, the uncertainties, negative health reports, and even the fear of unknown. I've had testimonials of how, spiritual support have been found to save expected mothers from depression, suicidal thoughts, and even complications. There was a study done by NIH in 2018 on mothers and expectant mothers, and the results show that enhancing the patient's spiritual beliefs lead the patient to achieve good results in any situation, even die-hard diseases. So I believe this support is very necessary and important for women of color to experience a successful childbirth experience. So I think we need all this support.
Excellent. I think that after coming through the pandemic, one of the living legacies of COVID, what we've been living under for the past over a year, has been to have us understand the mind, body, spirit connection. I think that there will truly be a healing that needs to take place in the months and years to come for what we've all been through. I'm sure that this will be picked up as a note in the conversation from the audience, but thank you for highlighting that importance. Thank you. So we're going to go back to Dr. Sutton. Dr. Sutton, we have a question for you. What are some ways that we, the fellow panelists and those who will be watching this presentation and with us tonight, what can we do to strengthen preventative and supportive care for mothers before and after childbirth?
Thank you for that question. So, I think I think we have to look at it aligned with the trimesters, or, look at it as what we can do before the pregnancy, during the pregnancy, and after. And I think before the pregnancy, one of the biggest things we can do is just try to be as expansive and as open-minded as possible so that all women of reproductive age can get information that they need about reproductive health access, whether they are trying to prevent a pregnancy, whether they're trying to get pregnant, and when and if they do get pregnant, to help ensure that they have access to early and accessible prenatal care. A lot of that is tied to, advocating for different things in our communities. Some of us live in states where maybe Medicaid wasn't expanded. If there are women who have fallen out of insurance coverage, how do we advocate for them to help make sure they can get what they need? Or how do we engage with local community health centers so that, sliding fee scales are possible for women to be able to access what they need? And how do we help ensure that the providers at the places that people can access are accepting? Part of, there's a difference. There's accessible healthcare, and then there's acceptable healthcare. Because I have had some patients say, well, yes, they have evening hours, but people in that particular facility don't treat me well. And so, it's a matter of both. I think during the pregnancy process, the beauty of this panel here is that I think all the different players who can help facilitate improved preventive and supportive experiences for pregnant women are on this panel. So, it absolutely requires a full-on OB team. So it's, it's the OB, the midwife, the doulas, the social work support. All of those persons can have certainly a positive impact in helping to make sure a woman gets what she needs. When we're looking at postpartum, one of the things that I think across the country, many of us are fighting for is to try to move from this historical outdated system of a postpartum process or follow-up period being within the 6 to 8 weeks after you deliver. And the country as a whole is trying to move toward that full year after delivery being a time that's covered by insurance providers. That's absolutely something that's going to be a game changer for women. When we look at the maternal mortality numbers, yes, a huge numbers of the deaths occur while a woman is pregnant or right after pregnancy. But those deaths also happen up to a year after pregnancy. And so it's important to include that 1 year period for all the things that a woman might need. Sarah just spoke about some of the mental health needs that women have that needs to be, more strongly incorporated into that process. During this post-COVID period, it's been interesting to see the number of women who either weren't able to access care while they were pregnant, or somehow didn't make it back after a delivery, and they're having babies close together. So also in that postpartum period, for those women who might want birth control or contraception to delay the time in between babies, making that part of that postpartum follow-up as well. So I think there are, those are the areas that I would say need strengthening, particularly with the mental health piece. And if I can just mention, in pop culture, the last few weeks, if any of you guys saw the interview with Oprah and Meghan and Harry, I was struck. If you didn't see it, it was interesting to me that no one actually said the phrase postpartum depression or anxiety or something, because everything that was going on with her that she described happened while she was either pregnant with Archie, after pregnancy, and now she's pregnant again. And so I think we really don't do enough to try to understand and support women in that window where there's so much going on. And it's about so much more than just making sure that, the breastfeeding is okay and all the other stuff. There has to be a stronger mental health component, but because there's so much going on. I know I have 3 sons, and certainly with my first one, I had no idea what I was doing with breastfeeding. And so that support group was, it was just, it was vital. I only needed it for a few weeks, but it was interesting to be on the other side. For those of us who do this work with women, when I was in residency, I had not yet been a mom, and my perspective in terms of the feedback I would give women changed so much after I became a mom. I was like, girl, we've been breastfeeding for years. And then after you become a mom and you're doing it, and you're like, oh, this is harder than I thought. So it just, it sensitizes you to things in a different way. And I think, for any of us who have experienced it, to be able to share that experience and share those stories with women to help lift them up and reassure them that it's going to be okay, I think it makes a world of difference. And so, sorry for the long answer, but I think there's so much more that we can be doing for our women to get them what they need.
No, I appreciate that long answer. You hit on so many important points. The point that you raised about the paradigm shift that's happening in medicine and societally, that we're not looking at it in terms of 6 to 8 weeks, and then we'll see you next time, but extending that out to the 1-year period. The thing is that we have to have reimbursement that follows that. So it's one thing to say we should be doing it. It's another thing for the payers, the insurers, and for the government to cover those visits. So important. We can talk about Meghan and Harry. That would just take the conversation to another space because that's such a hot topic. But I think it speaks to the stigma that is still there within us culturally as a people in terms of mental health. That as much as there's an appreciation and bigger discussions happening, and we hear about it on the news, we're not necessarily invoking a sense that takes away from being ostracized when we have these conditions that are plaguing us. So very good points. I know that we are definitely triggering some ideas within the audience as I see the comments in the chat. So with that, I'd like to go back to Ashley. Thank you, Dr. Sutton. We'd like to go back to Ashley. And, just speaking of COVID, let's drill down a little bit on how the COVID experience has impacted the role that doulas play and have been able to play while we've been under lockdown and limited access in our homes. What's happened?
So it's definitely been a big change. The biggest change that I've really seen over the past year with my clients is how impacted their mental health is, the anxiety that they're feeling when they're pregnant. Partners are not allowed into appointments. I was at a birth a couple of weeks ago, and the partner said, "This is the first time I've heard the baby's heartbeat." And so pregnant women are going to even diagnostic appointments by themselves and having to make, decisions. And so the level of anxiety is just so much higher. So this past year has just been an incredible shift in really just being more of a doula than I think most doulas have ever been, because we just are caring for our clients in a much different way. Most hospitals have put restrictions in place, and so doulas have not been allowed to go. We are able to be on FaceTime or Zoom, but we're not able to be in the physical space with them. And so we're doing so much more with them before to kind of prepare them for their birth and really walk them through all of the different things. And then being available to them during their birth. I have been on, FaceTime with people throughout the entire birth, and they've said to me afterwards that I was the only person in the room that didn't have a mask on. And so they were able to focus on my face because everybody else in the room was very medical. They're having face shields. So people just need that connection so bad. This past year, other states have executive orders in place where doulas are allowed into the birth space, but unfortunately, right now Connecticut does not. I would love to be able to change that because it's now been an entire year. When this first started, it was like we'll probably be gone for 2 weeks, and now it's an entire year later, and people are still having babies. And the support that they can get from their own families, people can't travel here the same way to support that postpartum period. So isolation, people are just feeling like they don't have their people. And so I feel like doulas have just been needed so much more this past year than ever before.
Right. And, your point that you raised about how with all of the masks that are on, to make that connection through even telemedicine, how important that is. Even a year ago, we didn't do that. So it's interesting how we have advanced out of necessity to incorporate technology into the birthing experience. So who knows where that may go. Thank you.
Absolutely.
Thank you. Dr. Satin, we're going to go back to you and just speak to this issue because it's going on. We're all in the phases of vaccination right now. There's a lot of talk, particularly around communities of color, around the vaccines options that are out there in infertility. Is there any truth to this, or what are your thoughts on that?
Oh, thank you for that question. Great question. So no, there's no truth to that. Now that being said, let me also clarify that we're still in the early stages of learning about COVID-19. So there haven't been any studies definitively to look at COVID-19, the vaccines that are out there, and fertility. But there's absolutely no evidence. I know. So to date, there have been, I think, over 12,000 pregnant healthcare workers and or frontline workers or teachers who have been vaccinated since the vaccine became available in December. And the data that they have so far shows no problem in terms of those pregnant women and women who have gotten pregnant shortly after that. So far, they haven't documented any adverse outcomes. And I want to read you something actually that just came out about 2 days ago. And it's a joint statement from 3 professional bodies that kind of govern a lot of what you see in terms of obstetrics and gynecology. And the organizations are ACOG, the American College of OBGYN, the American Society for Reproductive Medicine, and the Society for Maternal Fetal Medicine. And so the statement says there's no loss of fertility that has been reported among trial participants or among the millions who have received the vaccine since their authorizations. And no signs of infertility appeared in animal studies. Very important to know that a lot of times before these vaccines are used in, well, all the time before these vaccines are used in humans, there are some animal studies done and there were no issues with infertility in those animals. And then furthermore, the Pfizer vaccine and Moderna, they're using the new mRNA technology. And even though the vaccines are new, the mRNA technology has been worked on for a long time. One of the lead investigators has been Dr. Kizzy Corbett at NIH. And those have not been associated with any adverse outcomes in terms of fertility or reproductive health. And the newest vaccine that's out there, Johnson & Johnson, is the same type of technology that's in the flu vaccine. And you guys know that the flu vaccine has been recommended across all trimesters, even for pregnant women and non-pregnant women for years now, and it has no adverse outcomes. So I just wanted to respond by sharing that information that, while we continue to collect data and learn as much as we can about COVID-19 as fast as we can, there's no data to suggest that these vaccines, which use technology that we've been using for years, there's nothing to suggest that they would have any adverse outcome to either fertility or to women while they're pregnant. And I'll say one other thing before I turn it back over to Dr. Achang. What we do know, and this is, I can tell you, I saw some stuff, a year ago, March 2020, April 2020, that really scared me. So what we do know, what the data does show, is that women who get COVID-19, who are already pregnant, are at higher risk of severe outcomes like preterm births, early labor, different types of infections. It's not a joke, a pregnant woman who is very sick with COVID-19. And what we know for sure is that women who have been vaccinated have not had those severe outcomes. So I'll leave it there. Thank you for the question.
Oh, you're most welcome. Thank you, Dr. Sutton. We're going to transition into education awareness, and your comments resonate because it speaks to this conversation that the media has picked up on vaccine hesitancy. But a lot of this drills down to the fact that we have justifiable reasons as a people to be leery and not having trust in a system that in many ways has not been trustworthy. And the explanation that you've provided with data that is informed and current, speaks to the fact that all we're asking for is to have our questions answered. So thank you for that. Thank you for that. Okay. So we're going to go on to the section, and please, those who are participating out there, write your questions and comments. We really appreciate your participation, and we'll get to that after this next section, which speaks to education and awareness. So for Whitley, I have this question for you. How is the importance of maternal awareness emphasized here in Connecticut and within the areas of New Haven and the surrounding counties of Hartford and New London? For those of us tonight who are not living here in Connecticut, the way that our state is, which is a state of counter to popular myth of haves and have-nots, most of our population, Black population and communities of color live in our cities of New Haven and Hartford and Bridgeport. So what's happening in terms of the whole scene with respect to the understanding of the importance of health awareness around maternal health?
So I'm glad that you've raised this question because, well, actually up until COVID, things were really on track with the state of Connecticut. We're making a lot of advancements, and a lot of organizations have become aware of the need for doulas and have tried to integrate doulas into their field of work to provide equitable support to their families. But there has been a large, obviously, halt on that work. But in the New Haven area, I know Dr. Canty raised a picture of Earth's Natural Touch, and they have partnerships with Healthy Start in their home visiting program. And so they're able to provide doula support to those families of first-time parents to ensure that they have the support, they're able to afford the support, and that the support they're receiving reflects the culture needed to be able to advance those families to reach their goals. Ashley and I have also both had partnerships on a state level with one of the state organizations that's providing support for inmates in the prison. However, we've had to put a halt onto that with the effects of COVID. So there is some advancements to ensure that inmates are able to receive doula supports when they're entering the prisons to give birth, as well as some of the other home visiting support programs here in the greater Hartford area. There's some advancement and some work happening there to try and get doulas to be of support with those families as well as teens. We just finished wrapping up a support program where we were able to provide teens education as well as doula support and lactation support to ensure that they're having healthy outcomes here in the greater Hartford area. And that was phenomenal. We really were able to provide some really great resources to our teens because we've noticed that gap between their parents breastfeeding and then now being able to teach the teens how to breastfeed or what's that like. So there's been some work there as well as on a legislative level to get doula care to be covered by Medicare. So there's some work being done here in the state of Connecticut. It's unfortunately being derailed because of COVID, but there's still a lot of work happening behind the scenes.
Mm-hmm. Thank you for that answer. I mean, it's so important that we have a focus on this and we use the legislative influence that we have as communities of color to affect those changes. Thank you. Thank you so much, Whitley. Sarah, I have a question for you. What kind of conversations, for those that are in the field and for those who are just allies in this effort of addressing reproductive justice and that everyone is able to have access to the care that's needed to optimize their pregnancy outcomes, but what kind of conversations can we and those who are participating, can we spark between patients and physicians to address the maternal mortality crisis? And where do we even start? It seems like such a big problem. Where can we start?
Thank you. Where do we start? So I think that the healthcare workers can initiate a conversation with the community, discussing the importance of receiving care during pregnancy and how skilled care before, during, and after childbirth can save the lives of women and newborns. Also, we can talk about how physicians need to give adequate attention to every patient and also foster an environment that ensures that the patients are willing to receive the care, whether they think they need it or not. And we can extend the conversation to how we can end disparities in women's access to healthcare, women's health education, women's health advocacy, which is of course a leading factor to lower quality care and higher morbidity and mortality rates among women of color. So we can raise those, those conversations can be, we can have those conversations with the community. Of course, according to CDC, about 700 women die each year in the United States as a result of pregnancy or delivery complications. So education is key. The community needs to be informed. We need to, educate them, probably figure out ways to educate and inform our communities about this crisis by discussing facts, statistics, testimonials, or experiences. So I definitely think that this will also bridge the gap between the physician and the patients.
Thank you. Thank you so much. I think that this is important, that we just need to start the conversation. I think discussions like what we're having tonight sparks that conversation. Thank you. Dr. Sutton, what are some ways that we can stimulate positive lessons that have been learned in other communities? Say the work that Dr. Laurel in Atlanta, Georgia, or in Chicago and other communities are doing. What can we do? Because ultimately we have to learn and grow so that we can scale up locally and to a national level. So what lessons can be learned from places that are doing it right?
That's a great question. I think, what I find working with patients is that each time it's very different. And each time, particularly, depending on where I am, whether it's Atlanta or Augusta or something like that, looking for resources has to restart with each patient. Each patient has slightly different needs. And it's also important because sometimes there are different cultural alignments that you want when you're looking for different support persons for, particularly for patients who are women of color. I think one of the things that would be really helpful would be like a centralized database of resources that women can access, either right before they get pregnant or as soon as they get pregnant. Something that says, put in your zip code of, if you live here, here are some user-friendly obstetricians, midwives, and doulas who you might want to reach out to, who can be part of your support team. Or, if it's either available to the women themselves, but also available at the different provider offices. I think part of this retraining is going to have to involve providers as well. Providers who have been kind of slower to get on board with the expanded OB team approach, doing some of this training with them as well, whether it's through our organizations like ACOG, or maybe it's at the state level when we do our annual or biannual state license renewals. Some of these things can be embedded in that as part of the process to make sure that we all have similar information and that we understand the urgency that's going on in terms of maternal mortality. I think that's one thing that we can do. Another really good lesson learned that's coming out of California, you know, we've been talking about maternal mortality, and certainly there's a piece of that that involves bias and racism. In California, you guys may be aware that what they started to do was to standardize some protocols. And so, for example, if a woman comes in and her blood pressures, I think someone described 170 over 110, standardized protocols make it make sure that it takes the decision away from that provider. So if you see a non-Hispanic white woman with that blood pressure and you're thinking, oh, let me get her some medicine, let me admit her, let me check this and that, that protocol says you have to do the exact same thing for a Black or brown woman. And so it removes that subjective process whereby you can decrease some of the bias and the racism. So far, it's shown to be working well in California, and I think other states and other localities can probably take some of those lessons learned and implement them so that we have, you know, these stories when we look at the outcomes and we see that when you drill it down to what happened, it was really a matter of that provider not treating that woman appropriately or respectfully, probably based on her color, her race, or ethnicity. You know, you really want to, you really wonder if some of these protocols can be more widely implemented to get to the root of some of that, you know? So I think those would definitely be two things that I would say would be important to build upon and try to replicate in areas where we have challenges, which unfortunately is the whole country, disproportionately in the South, though.
Yeah, so true. Dr. Sutton, the point you made about the variability, physician variability, is so real. And I believe that that's the next frontier. Having been in organized medicine for over 20 years now, I appreciate how there's different strokes for different folks behind the scenes. And I think that if we do standardize those processes, and certainly the Kaiser models have pointed to that, understanding that that is a key element to health equity, and that we take out this ability of physicians to make calls based on things they don't even realize. They're doing things and instinctually not appreciating it. A woman is presenting, a Black woman is presenting with chest pain, and they're thinking that it's something to do with the gallbladder, but she's having a heart attack. So there's science behind that. And I hope that in the years to come, there'll be a greater appreciation among the physicians and providers who are coming up through the system, but also the investment of systems to do research and to build data so that we understand what drives a lot of this change that we see. So thank you. Thank you. I'm sure that that'll be picked up in our discussion from the participants. So Ashley, I have a question for you. How can community members, people who are interested in doula services, find out what's out there? It may not necessarily be something that comes top of mind. And if they do know about it, how do they access these services? And for those of us that are involved or want to get more involved with promoting the work of doulas, where should we go?
So Whitley and I are both doulas, and we're really connected to the doula community in Connecticut. We are often getting calls to kind of be helping clients connect to other doulas if we can't serve them ourselves. We also have some great services right in Connecticut. So Earth's Natural Touch has been mentioned, you know, several times tonight as far as doulas of color. There are also some registries that people can look up. There is a website called System Midwife and Doula Registry, as well as National Black Doulas. So people can kind of, you know, look those up. There's also doulamatch.com, which is just a national registry of all different types of doulas. And for people who are looking to really promote the work of doulas in the state of Connecticut, there's a Facebook page called Doulas for CT. So you can look that up and you can like it. And there's always announcements on there about what's going on in Connecticut. There's a lot of advocacy going on as far as getting Medicaid to reimburse doulas. So all of the sort of happenings are going to be on that Facebook page, Doulas for CT.
Thank you for that information. I'm sure that everyone is taking that down. So important. So what I'd like to do at this point, we have some questions for all of the panelists. So please weigh in, and then we're going to open it up to our audience. So to all our panelists, if there is just one thing, if you had that magic ball and you could say one thing we can do to be better advocates for maternal health, what would that be? Anybody to comment on that?
So I would say Medicaid reimbursement is probably one of the best we can do, because that is going to allow all different kinds of families to access the support. Right now, unfortunately, like everybody has said, it is very expensive to hire a doula out of pocket. It's really sad because doulas need to be compensated for their time and their time away from their families, and this is our income. But unfortunately, that means that it's not accessible. So Medicaid reimbursement for sure.
Okay. Any other comments from the panelists?
Yeah, I think that would make a huge difference, Ashley, if our doulas were able to get some type of consistent reimbursement. I think more patients absolutely would use them. I love what Whitley said earlier, because I had never thought of that, but now I'm thinking, goodness, every baby shower that I get invited to, I'm going to try to go in with a few people and see if we can get enough funds to get like a doula gift card, or, you know, just give them something to support them if they choose to hire a doula. I think that's a great idea. Another thing I think is important is, you know, if women, especially women of color, have a bad experience with a provider, I think there should be some type of telephone tree or some type of network where we share that information with other women so that they don't go to that person and have another bad experience. I think, you know, not trying to take away from anyone's business or anything, but with the eye on the prize of keeping as many women as possible safe and healthy, I think it's really important that women share when and if they have a bad experience, or on the opposite side, when and if they have a good experience, so that more women can go to that provider and engage that provider in their care and have the best outcome possible for them and their baby and their families. So I would say those two things.
Perfect. If I can add to that, I would also say asking the right questions. So ask more questions. When our friends and family members say that they are expecting or they're having a baby, we typically ask, do you know the gender? How far along are you? I would like people to start challenging their peers and ask, well, do you know what a doula is? Have you looked into having a doula? Where do you plan on giving birth? And then asking why did they choose that hospital? Because oftentimes they're going to that hospital because their mother gave birth there, not because they're going to get the best care. And so I would just simply add asking questions to challenge those people that were around to think a little bit more in depth before making decisions.
And also, I think that we can advocate or support a mother who is in need of help, and especially in the underserved communities.
Excellent, excellent. So Chi, I think at this time I'd like to entertain questions from our audience. I know that there's a lot of activity in the chat room. Any comments, questions that we'd like to talk over?
Absolutely. So we've had a lot of really great interactions in the chat with a lot of you just putting information about doula services, which we're collecting and we'll compile and send out in our email to our attendees. But at this time, we really want to open the floor to take about 1 or 2 questions from anyone who directly wants to ask one of our panelists or our guest speaker, Dr. Kanti, or even Dr. Achong herself. So feel free to take yourself off mute and just go right ahead.
Can I ask a question of the panelists and Dr. Kanti?
Sure.
Can you share more information about the international lens? Are doulas used in other countries heavily? And thinking of moms who may be new to living in the States, how do we help them not only access doula services, but thinking of just the language barrier? Have you found difficulty with that aspect?
That's a great question. It's probably going to be different by states. I'm currently in Georgia, and I know that over the last few years, we've had increased challenges with OB access services for women who were newly arriving into the US. One thing I think, though, that did improve over the last year or so is that in terms of language barriers and some of those things that we discussed during a visit, that has gotten better. There are numbers in Georgia that we can now call and reach someone who can speak any language. And although that may be standard in many other states in the country, it hasn't necessarily been standard in parts of Georgia. And so I would say that's one thing that has definitely helped. But the bigger picture I know from many of my women in Georgia has been access, because access decreased significantly over the last few years with the previous administration for a variety of reasons, including for those who get Medicaid, lack of access. And certainly during 2020, a significant number of women lost employment and lost insurance connected to that employment due to COVID. So, so that would be my response there.
Thank you.
Any other questions from our audience? You just take yourself off mute.
I'll ask a question. So my name is Ashley and I am actually in a hospital right now. So I'm really sorry if you can't hear me very well because I have to be kind of quiet.
We can hear you. That's
Okay,
okay, Ashley, we can hear you.
So I am a student at the Yale School of Nursing, and our slogan is actually better health for all. And I think we have a lot of work to do in order to meet that slogan. I don't think we work enough with you guys, and I don't think we work enough with New Haven. What would you guys like to see from nursing students more, particularly nursing students who live in New Haven? How can we be more, I don't know if contributory is a word, but I'm going to throw it out there. How can we support the community that we live in? You know, because you guys support us, we should be doing more for the community that we are part of.
I think that's an excellent question. And, you know, when we're looking at even just the treatment of patients in the hospital, nurses are at the core, and sometimes they're part of the problem. So it's important for, you know, as you're getting your training, to be aware, you know, of implicit bias and to address that. But also learn the communities that you're going to work with. Learn about the trauma, learn about what's going on, learn about the challenges that they face. You know, even when they do come in for care, look at how they're being treated, and also just being an advocate for them. And just recognize, like with doulas, they're there to support the woman and make sure that she has a good experience. Sometimes providers are so, I don't want to say insecure, but sensitive. I'll say sensitive, that they're like, oh, she's going to come in here and tell me what I need to do. So they don't even give doulas a chance. So they have to be confident in what they're doing and understand that women have the right to ask questions. And doulas are there just to help and support so that the woman can make an informed decision. Because we all know there's informed consent when you just sign the form, and there's true informed consent. And we know how our healthcare system functions. So it should be normal for women to ask questions and to have someone there to advocate for them. It's not about the provider, it's about the woman and what she needs as well. And if she just wants to make an informed decision. So it's just, again, as nurses, to learn that and learn how to advocate, because sometimes nurses sit there, and I'm sorry, I've seen it with my own eyes. They sit there and they allow women to be treated any kind of way. And there's just something special about that woman in childbirth. She's so vulnerable. So that this is a time where they need someone the most to just be there for them.
Thank you.
Would anybody else like to weigh in on Ashley's question about what nursing students can do and other students can do in the health professional sciences? You know, what I would add to that comment from Dr. Canty is that given everything that's been happening in the country in terms of the pandemics as they have been, in terms of racial issues and racism, I oftentimes am questioned by colleagues and friends about who are white. Well, what can I do? You know, racism is bad, but what can I do? And I think that what students can do beyond advocating is also, for those who are on this meeting tonight, I believe that we are like-minded and we are the choir, so to speak. But for those who have the ability to influence others, I would influence your other student colleagues to speak out when they see speak out in anti-racism, when they see that within health systems, small and large. As I'm sure all of us on this meeting tonight can speak to the fact that when we see things that are not right, to speak against that. And for those of us who are outside of the communities of color, when they see that, encourage your friends to address those issues real time so that change can happen and we can raise our voices and we can have issues that are wrong amplified.
So Dr. Chung, we actually have a question in the chat for Sarah. And so the question, Sarah, is through the work that you do in your foundation, do you believe that women in countries you serve will benefit from doulas?
Thank you so much. Most definitely. And I know that women in other countries, they're not even aware of doula services. You know, the most that we've seen family members accompany them, you know, to the hospital when they're about to deliver. But doula services, it's new. I don't think they're aware of it. So I'm pretty sure that it's something that they would benefit and really appreciate, you know. But sometimes these women, when they're alone, yes, they do have midwives, they do have nurses, doctors, but to have a doula will be beneficial to them.
I think that was the only question that we got in the chat, and Ashley Johnson asked that question.
Excellent, excellent. So what I'd like to know is from the panelists, something that has occurred to me is that we're speaking of raising the voice of those that are voiceless. In terms of those who are undocumented, we have significant migrant and undocumented populations here in Connecticut, as we are a corridor between New York City and Boston. Speaking to those populations, are there any thoughts from the panelists about how we outreach and target the special needs and vulnerabilities of these communities? Any thoughts on that? Immigrant and undocumented populations.
You know, in a state like Georgia, you know, in the South and very red, it really does require a lot of policy work. And, you know, I find that many of us are, you know, we've all been kind of busy these last few years. And so there are many people who are feeling kind of burnt out. But it's so important to, you know, as we're working with, you know, the young sister who brought up students and other folks, as new folks are coming into this area of maternal and child health and wanting to be advocates, it's important to support them and mentor them and help encourage them to keep at the work. I'm finding that more women who are, you know, new immigrants aren't able to access earlier prenatal care because they're not able to access some of the insurance resources that maybe they were able to access before. And so to the extent that we have providers who are willing to care for them, hospitals that will receive them and make it less scary because they're not going to send them some big bill at the end of the process. You know, there have to be so many different conversations so that we can create safe spaces so that the women feel comfortable coming in and getting the care that they need. And I know that it's different in each state, but that's what I would say for the area where we are.
Excellent. Thank you. Thank you, Dr. Sutton, for those comments. It's important to highlight the challenges of these unique populations who are under-resourced. So with that, Chi, I'd like to perhaps introduce Zaria Smith. Is that all right, Chi? Unless you have questions.
No, I think we're just getting a lot of thank yous from colleagues and for our attendees in the chat. We do have one quick question, if we can definitely ask, and it's from Dr. Evans. And so she thanks Dr. Canty and you, Dr. Chong. And so she says those individual levels are important, but many would agree that the world is a system problem as well, which is harder to address or get people to see. do you think we should be working on the structural racism in medicine and especially maternal care? And so Dr. Chung or Dr. Canty, you can answer this one.
Yes, I definitely agree with that. I think because the personally mediated, we can kind of handle that if someone comes in, well, I should say most cases, because there are people who are doctors, nurse midwives. And I do want to say on that too, in my study, there were nurse midwives that were not treating patients appropriately either. So I've seen it across the board with different providers. But we don't have a system that holds those people accountable. And if you hear some of the stories, the way that they talk to patients, how I had a patient who's told me that she was getting an exam and the doctor pushed her leg and, you know, she complained, but then there's no accountability. So we really do have to look at those structures in place. We have to look at why is it challenging to get doula care? You know, something that can be, to have a strong impact on health outcomes. What's in place as now, it's because it's so expensive. So someone who has money can afford it, and someone who can't, who could really benefit, cannot. So we got to really look at those structures that are in place. And the thing though with structural racism that makes it so difficult is it's so subtle and it's so invisible that you don't even know that it's happening till after the fact. So we really have to have someone who takes the time and looks at all these policies and procedures and wonder, even, I'm just surprised that people aren't alarmed that women of color have poor health outcomes and why they're not like angry about it. It's like when I hear these numbers or you hear the stories, you know, when you look at from the March of Dimes, how they talk about Black women who are doing the right thing, getting care, and they die, it's like, how come people aren't more angry? So we really do have to look at these systems, but it's so complex. And sometimes it's painful to look at it because we're all working in the system. And it's painful to feel like, oh God, I've been going along with this for all these years that we don't want to look at it. So we have to do that. We have to start by looking at ourselves and see where we sit in this. I think that's the first step. It doesn't matter if you're a student, if you're a doctor, if you're a nurse, nurse midwife, it doesn't matter. You can do something to address these structural issues. Sometimes just saying something and bringing awareness could be the start. It's going to take time, but we have to just talk about it. We have to talk about it and not be afraid to look at what we've created in our healthcare system.
Thank you, Dr. Kante. What I would add to that is that over my years of practice, I have seen that there is a change. And I think oftentimes when we think about issues of racism and race and white supremacy that affect the lives of others that are the underserved or minority, so-called minority communities, it's always the refrain, there's more to go. And there is more to go. And I have seen that change. I think that there are conversations that are being had that weren't had 20 years ago, and that's important. There's a lot of scholarly work around the social determinants or the social drivers of health, which is a whole other discussion that I'm hoping that NAHSE picks up as well, in terms of dealing with things that are beyond what the touch of any provider can do, in terms of what are the issues of transportation and housing and education and societal barriers to having our best bodies and our optimized health and wellness. I think the conversations are being had. I know that the large medical groups of which I'm a part of and I represent the state, you know, I am fighting along with others to champion that we do just have fairness and equality, and that we finally achieve those promises. That is the American story. So I want to thank everyone for that comments and that question as well. So with that, I'd like to introduce Zaria Smith, who does advocacy for NAHSE, who's going to close us out. I just want to say that it's been my pleasure to be your moderator tonight. And with that, I'd like to hand it over to Zaria.
Thank you so much. And I just want to thank all the panelists for being here today and taking the time out of your busy weeks to come and talk to us about this very pervasive issue within our community. And I also want to thank you for all the work you do to help individuals, especially women that look like me. And I can't applaud your work enough. So thank you so much. So as members of this panel have already sort of stated, Doulas, or have already shown, doulas can be instrumental in mitigating maternal health disparities, especially within the Black community. So use of doulas has been correlated with things such as a lower likelihood of having a cesarean, shorter labor lengths, increased breastfeeding success, decreased stress and anxiety, as well as so much more. But there's still a lot of work to be done, which, I think this panel has definitely conveyed that very effectively. So although doulas are essential to Black maternal health, they still remain fairly inaccessible for those in our community. So right now, only 2 states, Oregon and Minnesota, provide Medicaid reimbursement for doula services. So therefore, for many low-income Black families, Black and brown individuals, doula services, while again a pivotal component of health, is still seen as very much a luxury item. So in Connecticut, there are some steps being taken to increase access to doula services for communities of color. So recently, the Connecticut Public Health Committee has had a hearing for Senate Bill number 1, which does 2 things with regard to the doula profession. So first, it actually defines the term doula, and it defines it as a trained non-medical professional who provides continuous physical, emotional, and informational support to a pregnant person during the antepartum and intrapartum periods, and up to the first 6 weeks of the postpartum period. And then the second thing that the bill does is that it also requires the Commissioner of Public Health to conduct a study to determine whether or not the state should establish a certification process for doulas. So while this is a decent first step, obviously these 2 action items don't quite do what we need them to do, right? Simply passing this bill isn't necessarily going to change the maternal health disparity that we're seeing now within the Black community. So as many of the individuals in our panel have already stated, what we need to do, right, is design and implement a reimbursement structure to ensure that doulas are appropriately reimbursed for all of the services they administer. So just making sure that we're actually creating some sort of reimbursement model, but also ensuring that the amount that doulas are being paid for their services, for all the time and care that they devote to Black women and Black mothers, is enough, right? It is sustainable and is worth it, given all of the training they go through, et cetera. Also providing funding for the training of Black and brown doulas who might see licensing and training costs as a barrier to entering the profession. So I remember some of the individuals have mentioned, the language barrier, or, having access to doulas who look like you or might understand who you're going through. Since that's such an instrumental part of what doulas do, right, is really giving that emotional support. There has to be sort of an understanding there has to be representation of doulas that come from our community that truly understand what we are going through if we do want to close these maternal health disparities. So ensuring that, again, costs and these licensing costs and these training costs aren't barriers for people like us to come into the profession is definitely something that needs to be looked into. And then I've heard a lot of this tonight as well, but educating our community on the role of doulas and how and where we can seek out these different services, because again, a lot of us don't know necessarily what a doula is, where we can get one, where even a doula sort of operates. So making sure that we're informing our community of, where we can find these resources is going to be the next critical step in closing these maternal health disparities. And so what you all can do to support doulas and Black mothers across the state of Connecticut is, of course, first and foremost, support your local doulas and Black women in general, and that should just be every day, all day. But I think there's been a lot of different organizations that have been put in the chat. I like the idea of the baby shower, providing doula services as sort of a baby shower gift, I think is great. And then also make sure you're supporting Black women throughout their pregnancies, of course, again, through asking questions. And, just overall, just being able to be a supportive individual throughout the whole labor and delivery process is really going to be important in reducing the stress and anxiety that Black women go through while pregnant. Also, you can contact members of the Legislative Public Health Committee if you are interested in supporting Senate Bill 1, again, which outlines the definition of a doula and commissions that study. And then one thing that I sort of added last minute, given the conversation that we've had, is coalition building. So there's, been a lot of discussion about what we can do to sort of support, again, doulas and Black mothers within the state. And NAHSE, we host these events, of course, to educate the community and educate our members about the different issues that are going on with regard to health within the state of Connecticut, but we also host these events to sort of connect everyone, within the community, right? So we have individuals here who are representing Yale New Haven Health. We have individuals here who are representing Trinity Health System. We have students from, the Yale School of Public Health, Yale School of Nursing. We have doulas, and we have these accrediting bodies. And so I can understand how, as an individual, it may be hard to speak up, in support of certain types of legislation, or sticking up even at work to ensure that individuals are being held accountable for their actions. But that's going to look really different, right? If you have the weight of these hospitals and these academic institutions, and all of these different professional services behind you, supporting you. So I would definitely encourage you all to sort of reach out to each other, connect with one another, and see how we can really come together and sort of solve this issue that is so pervasive, again, within our community. And apologize. So to close out, I'm going to turn it over to Kim, who is the president of the National Association of Hispanic Nurses for the Hartford chapter. So thank you all so much.
Great job, Zaria. That was a beautiful summation, and I look forward to everyone getting all of the wonderful websites and organizations that were noted. So thank you, Chi and NAHSE Connecticut, for inviting NAHN Hartford to partner for this evening's event. I think what we're trying to do is raise awareness, and for us in particular, we know that women who identify as Afro-Latina and are perceived as Black women in the community are also experiencing terrible maternal outcomes, and so we're trying to center the experience of Black women. And we so appreciate Dr. Canty's research to really understand and unpack what women are going through. And the second layer of that is in nursing in particular, we're trying to just deepen the understanding, increase cultural sensitivity and awareness, and kind of help students understand that this is a lifelong learning, and really just getting on board with stating that racism is a public health crisis. So we're definitely grateful to partner, look forward to the recording being shared broadly, and I'm hoping as we move forward that we can get more of our white colleagues to attend events like this, so that in healthcare, and we know nursing is recorded as the most trusted profession, that we can take more pride in knowing that our organizations are stopping these disparities. So thank you all for a wonderful evening. We appreciate being here and learning.
Thank you so much, Kim. Thank you to Dr. Chung, our moderator, our esteemed panelists, our partners at NAHN. We look forward to sharing the information with you all that was shared in the chat. Thank you to NAHSE Connecticut, the entire executive board, who really helped lift up this program. So thank you for spending your evening with us, and everyone have a blessed rest of the week and a safe night. Thank you.
Thank you.
Thank you.